Back to another session of biochemistry classes. So we'll go. Last class we finished with metabolism of phenylalanine and tyrosine. So this class we'll continue with the metabolic disorders of these pathway. So the metabolic disorders of phenylalanine and tyrosine. So when we talk about the metabolic disorders, it is nothing but inborn errors of metabolism. So what is the first one is the phenylketonuria. It is an inborn error of phenylalanine metabolism. It is an autosomal recessive disorder seen 1 in 25,000 births due to defect in phenylalanine hydroxylase enzyme. There is elevated levels of phenylalanine in the blood. It is caused due to another enzyme also, that is dihydrobiopterin reductase, right? So this helps in regeneration of tetrahydrobiopterin. So we'll have a look at the reaction. So phenylalanine gets converted to tyrosine in the presence of phenylalanine hydroxylase. Tetrahydrobiopterin utilizes oxygen to get converted to dihydrobiopterin and a water molecule. So in PKU of phenylketonuria, phenylalanine hydroxylase enzyme is deficient. So what is this? We'll see. There is defect in the phenylalanine hydroxylase enzyme. We call it as classical phenylketonuria or PKU. The alternate pathway catabolites of phenylalanine, you have phenyl pyruvate, phenyl lactate and phenyl acetate is formed. So phenyl acetyl glutamate is excreted in the urine. So here you can see in this reaction, phenylalanine by transamination reaction gets converted to phenyl pyruvate. Alpha ketoglutarate gets converted to glutamate. So phenyl pyruvate by oxidative decarboxylation gets converted to phenyl acetate, and by reduction it gets converted to phenyl lactate. Now this phenyl acetate gets converted to phenyl acetyl glutamine, where glutamine gets converted to gives a water molecule. So these are the alternate pathways of phenylalanine catabolism in PKU. So we can classify PKU into the classical phenylketonuria or type 1 hyperphenylalemia, where the defect in the enzyme is phenylalanine hydroxylase enzyme. And then you have atypical phenylketonuria, which we call it as hyperphenylalaninemia type 2 and type 3, where there is defect in dihydrobiopterin reductase enzyme. And then you have hyperphenylalaninemia type 4 and 5, where there is defect in dihydrobiopterin synthesis. Okay, so this is the classification of PKU. So what is the characteristics of phenylketonuria? You have CNS manifestation mainly, okay, that is mental retardation. Then you have tremors, convulsions, then you have agitation, and also certain dermatological manifestation, that is hypopigmentation, right? And then you have mousy smell of urine. Okay, now what are the laboratory diagnosis of phenylketonuria? So you have, there is elevated blood phenylalanine levels. So the normal levels is 1 milligram per deciliter. Anything more than 20 milligrams per deciliter is seen in PKU. And then you have the tandem mass spectroscopy, which is the most reliable test. And then you have the ferric chloride test. Okay, you take the patient's urine sample, add few drops of ferric chloride. A transient blue or green color is positive. Okay, so the urine of the patient contains phenyl ketones, that's around 500 to 3000 milligrams per day. Okay, so then you have certain DNA probes that are used to diagnose the defects in phenylalanine hydroxylase and dihydrobiopterin deficiency. Okay, then you have certain other tests also which is more specific, like the Q-TREACE test, which we call it as a rapid screening test to diagnose PKU. So how do you do this test? You take a small drop of blood taken from the heel of the newborn, and it is applied to a card or a punched out of a dried disc which is incubated on a petri dish plated with a bacteria which is Bacillus subtilis in the presence of a growth inhibitor which is nothing but beta 2 thiethylene aniline. Okay, any high levels of phenylalanine in the blood sample, it overcomes the inhibition and allows the bacteria to grow. Okay, so if an elevated level of phenylalanine is detected, the child is placed on a phenylalanine restricted diet. So here in this picture you can see this is how you collect the sample from the newborn, that is from the heel, and this sample is applied on a disc which contains the bacteria probe, okay, that spores and also the inhibitor. Okay, any increase in phenylalanine levels, you will see that there will be bacterial growth. Okay, so this will be positive. So how's the treatment of this? You do an early reduction and then a low levels of phenylalanine diet should be given to these patients up to 15 years, right? So next we'll go on to the other metabolic disorder, that is tyrosine metabolism disorders, that is Alkaptonuria. So this you see 1 in 250,000 births. The defect here is homogenetic acid oxidase. So this was first found by Dr. Garrods, and we call it as Garrods tetrad, which includes Alkaptonuria, Albinism, Phenylketonuria, and Cystinuria. Okay, so here what is the main thing? It is homogenetic oxidases defect. What happens? Homogenetic acid is present in the urine. It gets oxidized to give a black color on long standing. So homogenetic acid is oxidized to give benzoquinone acetate in the urine, and this gets polymerized to give a black color alkaptone bodies. Okay, so in this slide you can see a urine sample is taken from the patient. You can see here there is black color change in the surface. Okay, that's after some 15 minutes. Whereas this, you can see this test tube is completely changed black. This is after 2 hours. Okay, so this is Alkaptonuria. So how do you diagnose Alkaptonuria? First thing is urine becomes black on long standing when exposed to sunlight, and then you do the ferric chloride test which is also positive, and then Benedict's test is also strongly positive because homogeneous acid is a strong reducing agent. Okay, so this is about Alkaptonuria. The next inborn error you have is albinism. Okay, what is this? Here you see hypopigmentation of the skin, hair, and also of the eye, that is the iris. This is due to lack of melanin pigment. So what happens here? There is deficiency of tyrosinase enzyme which is not present in the melanocytes. So tyrosinase enzymes requires a coenzyme that is copper, and hence during even any copper deficiency you see there is a flat type of hair in the patients. So along with hypopigmentation they also come with photophobia, nystagmus, and also decreased visual acuity. Okay, so next we'll go on to the other tyrosine inborn error, that is tyrosinemia type 1. This deficiency of fumarate acetoacetate hydroxylase enzyme. There's accumulation of tyrosine and its alternate catabolites. Okay, so what happens here? There is liver failure, rickets, renal tubular dysfunction, and polyneuropathy. Next one is tyrosinemia type 2. Here the deficiency of tyrosine aminotransferase enzyme. There's mental retardation, painful corneal lesion, and photophobia. There's increased tyrosine excretion in the urine. Then you have the next one is neonatal tyrosinemia. This is due to absence of the enzyme phenylpyruvate hydroxylase enzyme. Okay, it causes transient hyperthyrosinemia in the newborn, and these newborn will respond to a treatment of whenever they are given vitamin C and dietary protein restriction. Okay, so this is about neonatal tyrosinemia. Next, we'll go on to another condition which uh, call it as pheochromocytoma. Okay, so before we go on to the proper pheochromocytoma, we'll just brush up with a tyrosine metabolism. So tyrosine, in the presence of tyrosine hydroxylase gets converted to dopa, and this dopa by decarboxylation gets converted to dopamine. So dopamine and dopa both are neurotransmitters. So deficiency of these will lead to Parkinson's disease. Okay, now this dopamine in the presence of an hydroxylase enzyme and copper and vitamin C gets converted to norepinephrine. This norepinephrine, by getting a methyl group from SAM, gets converted to epinephrine. This epinephrine gets converted to metanephrine in the presence of catecholamine methyl transferase enzyme. Metanephrine, again in the presence of monooxidase enzyme, gets converted to vanillamic acid. Okay, that is VMA, and this VMA gets excreted in the urine. Okay, so now we look into the VMA, which is very important when we talk about pheochromocytoma. So what is pheochromocytoma? We'll just have a look. So catecholamine secreting tumor of chromaffin cells, typically which is located in the adrenals. Okay, it causes persistent or paroxysmal hypertension in the patients. So diagnosis is by measuring the catecholamine product in the blood or in the urine. So that is VMA is estimated, and then you have certain imaging tests, especially the CT scan or the MRI. And also, whenever there is increased level of blood sugar, blood pressure, you also have to give drugs to maintain the blood pressure in these patients. So now we also have to know what is VMA estimation. So the normal levels of VMA excretion is around 2 to 6 milligrams per day. So we take 24 hours urine sample. So whenever we do this test, we ask the patient not to take any chocolate, coffee, okay, any citrus fruits, because all this contains vanillin. And so increased levels is seen in pheochromocytoma and also in neuroblastoma. So 24 hours urine sample is taken. It is extracted. VMA is extracted by ethyl acetate. So it is oxidized with metadropinate to convert to VMA to vanillin. So this is extracted with toluene, and the color is red at 360 nanometers. So you have another urinary metabolite of dopa and dopamine, that is homovanillic acid, or we also call it as HVA. So whenever we take a ratio of HVA and VMA, if it is less than 1, there's good prognosis. Anything more than 1 is giving a very bad prognosis of that particular disease. That is, it can be either pheochromocytoma or neuroblastoma. Okay, so this finishes with the tyrosine and phenylalanine inborn errors of metabolism, right? So we'll go on to a few case reports which are pertaining to this inborn errors. Okay, we'll go on to the first one. A 2-week-old infant with refusal to feeds, lethargy, excessive cry and irritability tested positive for ferric chloride test on genetic screening for inborn errors of metabolism. So the laboratory findings, the serum phenylalanine is 30 milligrams per deciliter, serum tyrosine 2 milligrams per deciliter, urine is positive for phenyl ketones, that is the ferric chloride test is positive. So what is the probable diagnosis? What enzymatic reactions are defective in this patient? What are the physiological consequences, and why should it be detected as early as possible? And what is the treatment for this patient? Okay, so we'll go on to the answers. So what is it? It is phenylketonuria. It results from failure to convert phenylalanine to tyrosine. This conversion requires two enzymes, phenylalanine hydroxylase and dihydrobiopterin reductase, and PKU results from a genetic defect in either of these two enzymes, right? So most enzymes with PKU have a genetic defect in the gene for phenylalanine hydroxylase enzyme. So impaired conversion of phenylalanine to tyrosine causes accumulation of phenylalanine, which is catabolized by alternate pathways. So the normal range of blood phenylalanine is around 1 milligram per deciliter, and PKU, the blood alanine is increased more than 10 milligrams to 60 milligrams. In classic PKU, phenylalanine concentration increases more than 20 milligrams per deciliter, right? So what is it here? Again, as early detection is the best way of treatment, right? So as effect of phenylalanine and its metabolites on the brain development occurs very rapidly, early detection is important. It is found that the patient may lose 5 IQ points for every 10 weeks of delayed treatment. If the treatment is delayed for 3 years, the mental retardation is usually severe, and initiation of treatment at this time will not affect the brain development. Okay, so what is the treatment here? A low phenylalanine diet up to 15 years of age, okay, is the treatment for PKU. Next, we'll go on to another case report. A mother admitted a child to hospital with complaints the diaper used for the child stained black. Blackening of urine was observed on exposure. Laboratory findings: the Benedict's test with urine is positive. Glucose oxidase test is negative. Ferric chloride test is positive. Silver nitrate test with urine: the black color develops immediately. So what is the probable diagnosis? What is the biochemical defect? What are the complications of this disorder? So what is the diagnosis? It is black color urine, that is Alkaptonuria. It is an inborn error in the phenylalanine tyrosine pathway involving the deficiency of homogenetic acid oxidase that catalyzes the oxidation of homogenetic acid to malonyl acetoacetate. So as a result, homogeneity accumulates and auto-oxidizes, forming a black color pigment which discolors the urine and stains the diaper. So in the later life, there is arthritis, connective tissue pigmentation, onchronosis due to oxidation of homogeneity to benzoquinone acetate. So this is a case of alkaptonuria. Okay, so we'll go on to the last case report. So what does it say? A 2-month-old baby girl was brought by her parents for consultation. She had pale skin, blonde hair and pink iris. The baby was otherwise healthy, feeding well, but was unable to fix the gaze. The parents revealed that their first 2 children, a girl and a boy, had complete albinism, but the parents themselves were normal. The eye examination of the child showed absence of the pigment in the retina. What is a probable diagnosis? What is the biochemical abnormality of this disease? We'll go on to the answer. Yes, it is a case of albinism. Normal skin color is due to the melanin pigments, right? So the melanin, the amount and distribution of melanin in the skin forms the basis of the skin colors black and brown. So the clinical features here is white skin, white hair, no pigmentation in the eye, poor vision, photophobia and nystagmus. So this is a case of albinism. So today we did 3 cases, case report. One is phenylketonuria, alkaptonuria and albinism, right? And also we covered with the metabolic pathway errors, that is inborn errors of phenylalanine and tyrosine. Okay, so anything can come as a short note. Alkaptonuria, PKU, albinism can come as a short note, and also VMA is also a short note, and also sometimes it is most commonly asked by a question also. Okay, so this finishes with the first 2 aromatic amino acids. So in the next class we will go on to another aromatic amino acid. Which is it? It is tryptophan. Okay, So thank you. Have a nice day.